Welcome to our comprehensive guide on ECG interpretation basics. As nursing professionals, understanding how to read and interpret ECGs is a crucial skill that can make a significant difference in patient care. In this video, we'll cover everything from normal cardiac rhythms to critical abnormalities, and we'll finish with some practice questions to test your knowledge. Let's start with the fundamental components of an ECG. The P wave represents atrial depolarization and should appear as a small, smooth, rounded bump. The QRS complex shows ventricular depolarization and appears as a larger spike pattern. The T wave indicates ventricular repolarization. For normal measurements, the PR interval should be between 0.12 and 0.20 seconds, while the QRS duration typically ranges from 0.06 to 0.10 seconds. Normal sinus rhythm, or NSR, is our baseline for comparison. In NSR, we see a heart rate between 60 and 100 beats per minute with a regular rhythm. Each P wave is followed by a QRS complex in a consistent pattern. The PR interval remains normal, and the QRS complexes are narrow and uniform in shape. This is what we consider a healthy heart rhythm. Sinus bradycardia is characterized by a heart rate slower than 60 beats per minute. While the rhythm remains regular and we still see normal P waves and QRS complexes, the slower rate can be significant. Common causes include medications like beta blockers, increased vagal tone in athletes, or underlying medical conditions. While sometimes normal, bradycardia can also indicate problems requiring intervention. Moving to the opposite end of the spectrum, sinus tachycardia occurs when the heart rate exceeds 100 beats per minute. The rhythm stays regular with normal P waves and QRS complexes, just at a faster rate. This can be a normal response to exercise or stress, but it may also indicate fever, pain, blood loss, or other medical conditions requiring attention. Now let's explore atrial dysrhythmias, which are abnormalities originating in the atria of the heart. These rhythms can significantly impact patient hemodynamics and require careful monitoring and management. Understanding these patterns is crucial for providing appropriate care. Atrial fibrillation, commonly known as AFib, is characterized by chaotic electrical activity in the atria. You'll notice the absence of distinct P waves, replaced by fibrillatory waves, and an irregular rhythm. The RR intervals vary constantly, and this irregularity is a hallmark of AFib. This condition increases stroke risk and often requires anticoagulation. Atrial flutter presents with a distinctive sawtooth pattern of P waves, known as flutter waves, typically best seen in leads 2 and V1. The ventricular response is often regular, but can be variable. Flutter waves usually occur at a rate of 300 beats per minute, with the ventricles responding at a fraction of this rate due to natural blocking. We're now entering the critical territory of ventricular rhythms. These are often life-threatening arrhythmias that require immediate recognition and intervention. Quick, accurate identification of these rhythms can literally mean the difference between life and death. Ventricular tachycardia, or VTach, shows wide QRS complexes at a rate greater than 100 beats per minute. You won't see P waves, and the rhythm may be regular or slightly irregular. This is a medical emergency that can quickly deteriorate into more dangerous rhythms if not treated promptly. Ventricular fibrillation appears as chaotic, irregular electrical activity with no discernible pattern. There are no recognizable P waves or QRS complexes. This is a cardiac emergency requiring immediate defibrillation, as it means the heart is not effectively pumping blood. Asystole, often called flatline, shows no electrical activity on the ECG. This is cardiac standstill, no P waves, no QRS complexes, just a flat baseline. Immediate CPR is essential. While the prognosis is poor, prompt recognition and intervention give the best chance of survival. Pulseless electrical activity, or PEA, shows organized electrical activity on the ECG but produces no actual pulse. This can be deceptive because the rhythm might look normal, but the patient has no perfusion. Common causes include the H's and T's, hypovolemia, hypoxia, tension pneumothorax, and others. Let's examine AV blocks, which represent problems in the electrical conduction system between the atria and ventricles. These blocks can range from minor delays to complete disconnection of electrical communication between the upper and lower chambers. First-degree AV block shows a PR interval longer than 0.20 seconds. While the rhythm remains regular and all P waves conduct to the ventricles, this prolonged conduction time might indicate underlying heart disease. Usually, no immediate treatment is needed, but monitoring is important. Second-degree AV blocks come in two types. Mobitz type 1, or Wenckebach, shows progressive lengthening of the PR interval until a P wave fails to conduct. Mobitz type 2 shows consistent PR intervals with occasional dropped QRS complexes. Type 2 is generally more concerning and may require a pacemaker. Third-degree or complete heart block shows complete dissociation between P waves and QRS complexes. The atria and ventricles beat independently of each other. The ventricular escape rhythm is typically slow and unreliable, making this a serious condition often requiring immediate intervention. Let's practice what we've learned. Look at this rhythm strip. What type of rhythm is shown? Is it A, normal sinus rhythm, B, atrial fibrillation, C, sinus bradycardia, or D, first-degree AV block? Take a moment to analyze the strip. The correct answer is B, atrial fibrillation. Notice the irregular rhythm and absence of P waves, with fibrillatory waves between QRS complexes. Here's another scenario. A patient presents with a regular rhythm at 40 beats per minute with P waves present but no relationship to QRS complexes. What's your immediate nursing intervention? A, administer atropine, B, prepare for temporary pacing, C, give adenosine, or D, continue monitoring. The correct answer is B. This is complete heart block, requiring immediate preparation for temporary pacing. Thank you for joining us for this comprehensive review of ECG interpretation. Remember, practice makes perfect when it comes to rhythm recognition. Don't forget to subscribe to our channel for more nursing education content, and let us know in the comments what topics you'd like us to cover next.